they are still growing. So there may be craniofacial changes and also dental changes, for example, passive eruption and whatnot. So it may not be as straightforward as tooth replacement in an adult per se. So these children, if you were to if you were to plan for conventional bridges, for example, they may have large pulp cavity, and therefore, if you were to grind down the teeth for conventional bridge, you might risk causing loss of vitality in the pulp. You needing causing the teeth to die, as in to turn non-vital as a result, and needing root canal treatment lah. Dentures are also not very ideal because apparently if you spin the jaw while it's still growing, anything more than 8 hours, any appliance that you wear for more than 8 hours can act as alternative appliance. It may not be so ideal. You may limit the growth of the jaws, apparently, according to this study at the bottom lah. And then dental implants should obviously not be placed before groove termination in the anterior zone because there may be possibility of infraocclusion in the anterior zone if patients still exhibit late growth. Usually young women and also patients with long face, actually. They may continue growing into adulthood, like into the late 30s. Also cost issue in these patients because obviously they are still in school. They may not be able to afford those expensive treatment like implants and bridges and whatnot. And also because when they were, also the parents may not be able to afford these, and because this obviously the cost of prosthesis are not borne by the government, even though they were treated in the government setting, they still have to bear the cost, like the lab cost for these prosthesis. And then ultimately the local implant factors can also be unfavorable in patient with early loss of teeth, or with patient if patient do not develop. If patient have hypoplast, if patient do not have congenitally missing incisors, for example, there may be severe lack of alveolar groove width and often high, and the bone quality can be more cortical and brittle, making for more difficult surgical treatment with implants, for example. And then because there's no teeth at the side, the fixed gingiva, the keratinized mucosa in the area where the tooth is absent can also be very narrow or missing at all. So if you were to do like a bridge or implant, like the soft tissue profile may not be as nice as where a site where the teeth is present, I'll put it that way. So if you look at this picture on the lower right for me, yes, you can see there was a developmental missing 3141. So like you can see the ridge is very, very atrophic at this ridge. And also the keratinized mucosa width is actually quite narrow compared to the adjacent teeth lah. So that's what happens when you don't have teeth on that side lah. So the option for replacement of anterior teeth in growing individual is as below, orthodontic space closure, auto-transplantation. These first two options doesn't need prosthesis. And the next three options, which is denture, bridge, and implant, they are itself prosthesis lah. And then in the short term, you can actually replace missing teeth in the upper maxilla with wholly retainer orthodontic, such as this one in the picture. And you can also use S6 retainer orthodontic, and then denture. This is actually quite nicely made denture to replace the missing. It was for the case before, and this is the denture that replace. Sorry, this is the case. And then with after the bond, patient had a course of the treatment. After the bond, she had a set of temporary dentures made by the technician, which looks really nice. So auto-transplantation is not something that I'm familiar with, but I managed to read a bit into it. Apparently the success rate is quite high. So obviously it's an option in the case where you are missing upper or lower anterior teeth in very young individuals. So usually what they do is they transplant a premolar into the area of upper or lower incisor. If for example, the premolar has to be extracted for auto reasons. So there's nothing to lose, for example. So there's an example of a case on the right side that I took from this journal. So the premolar is transplanted into the true tooth side, so to speak. So the ideal time for transplantation is when the donor tooth has reached about 2/3 to 3/4 of the final tooth length. So immature teeth, immature premolars. If root development is already complete, if the tooth is already mature, you may need RCT within the first 2 weeks after transplantation, obviously with the splinting still in place. It's very important to keep the PDL cells on the root surface vital during the procedure. And it's very much like when you have an avulsed teeth, when the teeth is outside the mouth, to keep it in a suitable medium, or for example, so that you keep the PDL cells vital, so that when you transplant patient, there's a possibility that the tooth can still be viable in the long run. So after preparation of recipient site, obviously you have to create the osteotomy site, prepare it as you would like an implant osteotomy, so that the roots of the premolar will fit nicely into the socket, the fresh socket that you prepared. The transplanted tooth, once inserted, had to be sphinctered for 2 to 4 weeks, like you would a valve teeth, which was re-implanted, yes. So this is a case, again, I took it from this journal with the reference on the upper right. So this was a very nice case where the upper incisors were missing the 1-1 and 2-1. And then they took 2 premolars from either side of the arch and then transplant into the area using 3D guided techniques to prepare the osteotomy and ultimately to insert the teeth into the right position. So the pros for transplantation is that the transplanted teeth can be removed, can act like actual teeth. They're actually natural teeth, right? They can act like natural teeth. They're PDL. They have a bit of physiological mobility. They can be moved orthodontically. And they can also induce alveolar bone growth during the eruption process. They are like pretty much like nature has given you another go at having teeth, so to speak. So there's actually functional PDL in these cases. Because the tooth are, the transplanted teeth are pretty much functional. It allows for eruption of the teeth. It can promote gingival infill at definite site, and the gingival contour at that site is also nicer than that achieved with prosthetic alternatives alone. There's also very high survival and success rate in the literature. So if you these are 2 systematic reviews that's available regarding transplantation of transplantation mature teeth and mature teeth into upper anterior side, I think. And the survival rate and success rates are all in excess of 80s and 90%. I think even better than implant supported restorations, actually. So the cons for auto transplantation is that it requires considerable skill, knowledge and patience, and a careful surgical procedure. So the person who's doing it, the surgeon, has to be very skilled, possibly very experienced in doing it in order to get a very good outcome. And also, obviously, it has to be a multidisciplinary effort. You need like a good restorative dentist, a good orthodontist if ortho is needed at the outset and all that. So complication of auto transplantations, for example, inflammatory root resorption and chylosis and pulp necrosis, is very much like when you had a valve teeth re-implanted into the tooth socket. The same complication would have occurred because the tooth would have been outside the mouth for a period of time. So all these would have occurred. So with open apex, the chances are much better. You can get revascularization. However, with closed apex, you may need root canal treatment within the first few weeks with the spin seal in place. Orthodontic space closure is another option, which is very good to replace upper anterior teeth which were prematurely missing. These are a few cases that were sent to me by orthodontists. In my setting, generally, I work very closely with orthodontists, sometimes pediatric specialists, depending on what I practically share the same office with orthodontists, so we work very closely together. So these are cases where they're sent to us for restorative build-ups in order to camouflage a tooth as another tooth. So in this case, first case here on the upper left, there were 1-1 and 2-1 was extracted for some reasons. And then they moved the 1-2 and 2-2 into space of 1-1, 2-1 and sent to us for restorative camouflage. And then this was another case with missing 2-1, and the bottom was another case with missing 2-1 as well. So sometimes you need, with the build-ups, you kind of need to do a bit of gingival recontouring, either with laser or with cautery. For me, I use cautery a lot more than laser, but both works equally the same way. So the symmetrical scenario, such as the upper left here, is actually much better, easier to manage than the asymmetrical scenario, such as the upper right and the bottom case. Because to mimic natural teeth is actually quite hard, even with a crown and whatnot. We all know that. I mean, people who've done crown would have known it. To mimic it with composite restoration is equally hard. So if we have a case where it's symmetrically missing, like we have to restore 1-1 and 2-1, we can actually make it the same with composite restoration, but it's much harder. So if you were to only restore one with composite restoration, the other one is a natural teeth with some very unique characterization, such as fluorosis patches, like in this case of 1-1. So it's actually quite hard to match. This case was planned for, I think we planned for icon treatment for the 1-1, but so far we haven't called patient yet. So consideration for space closure vs space opening. This one you have to consult your orthodontist. Obviously, they will assess a lot of things. First and foremost, the facial profile of the patient, whether the patient has straight or convex or concave profile, or whether they have bimax sort of profile. Obviously I need to seek my opinion of the orthodontist. They know better lah. In which case, they have to assess the case individually, look at the crowding in the arches, the facial profile, and decide whether this case is more suited for space closure or space opening lah. Also, so the third option for replacement missing teeth in the upper axilla is denture. So this one we all know lah. This is our bread and butter. We do it on day out basis. Dentures can be interim prosthesis for space maintenance until you get a fixed prosthesis in time, or it can be a definitive prosthesis for those who refuse to have any treatment done, couldn't afford any treatment, or that can be the ultimate treatment. However, the downside is that it needs to be replaced every now and then because it tends to deteriorate either in appearance or it can fracture. You can have like changes in the oral mucosa, rendering it loose, rendering the fit to be not as good as before. Obviously, children are growing, so they need to be replaced now and again to ensure optimum fit of the denture. So with dentures, usually what you can do either acrylic denture or flexible denture . So there are diagrams on the right that shows the type of dentures that you can prescribe . So obviously, if you stay away from the gingival margin of the adjacent teeth, it will be better for the perio wise. So advantage of denture is multifold. It's such a versatile treatment option. It can be modified easily. You can reline rebase. You can add tooth. You can add clasps and whatnot. It can replace multiple saddles. You have missing teeth in the other parts of the arch as well. It can be removable to assist cleaning. And it's pretty much a reversible option because if this fails, you can still have other options are still open to you. You can still replace the missing teeth with like, so say for example, a bridge or an implant. It can even be an interim prosthesis, say if you're having implant treatment done, so that few months where you're awaiting osseointegration, you can have denture to replace the missing teeth for aesthetic purposes. The downside is that it has to be removable. It is removable for cleaning. It can be a good pros, but it can also be a cons because you have to remove it. So socially, it may not be that nice. It's not nice for you not to have teeth, say, at night if you were to remove it or whatnot. Also because there can be visible components such as class, and in the long run, it can cause ridge resorption. Complication of dentures are also multifold. For example, you can get, if not cleaned well, and obviously it's a prosthesis that carries plaque along with it, and then in close contact with teeth, you can predispose to caries, periodontal disease. And if the denture is not cleaned well, it's not fitting well, you can get denture stomatitis, and you can get resorption of residual ridge because if it's mucosal supported, not too supported, you can get very gross resorption of the underlying ridge. Sometimes you can get ulceration, and then technical failures can happen as well, such as loss of teeth, loss of fracture of denture and whatnot. So sometimes it's pleasant and unpleasant at the same time. So if all my friends who knew me know how much against flexible denture I am. So this is one of the cases I saw in my clinic. So I did like some work on the upper, and then the lower patient was wearing a sectional denture. So after finishing crown lengthening and whatnot, retreatment, post-core for the 2-3, he was asking, is it possible for him to have a fixed prosthesis on the lower arch? So if he was wearing a denture for years and years, a sectional foul plus denture for years and years, and when you took out the foul plus, you can see how much inflammation there is, and there's actually a cervical root decay on the adjacent abutment . And then you can see deeper inflammation. Luckily, he's not susceptible to perio, otherwise he would have had bone loss as well. So we actually replaced this missing teeth with a RBB, resin bonded bridge, as we'll come to later. And then 1 month after the cementation of the RBB, we let the inflammation resolve so that we can approach this decay. This decay was abutment for a 3-unit bridge, so we kind of sacrificed a bit of the retainer to gain access to the caries and restore it as is. So really not very nice. Flexible denture. Yeah, it is small in section, but then sometimes it can cause more harm than good. All right. So next we're going to come to resin bonded bridges, as we mentioned just now. These are actually, for the most part, I'm going to talk about resin bonded bridges because it's such a versatile treatment option. It's a very non-invasive, conservative treatment option for replacement of missing teeth, especially in the upper anterior zone or lower anterior zone. It requires minimal to no preparation of abutment. Really depends on what you are comfortable with, what your training dictates you to do, whether to prep or not to prep. For me, I was trained not to prep, but nowadays I do prep all of it, all intra-enamel, so that I get a bit of retention with my retainer. Even though it's a adhesively retained retainer, I do prefer a bit of retentive grooves, whatnot. But bear in mind, all your preparation had to be limited to enamel. Try not to prep into dentin, or else you might lose the bond strength. Okay, cemented adhesive resin cement, and then you need surface treatment because you need a fully adhesive protocol. Therefore, you need to treat the surface of the tooth enamel and also the fit surface of the retainer with some treatment depending on what material you use. So we're not going to go through the surface treatment. Suffice it to say that you can have two types, either the PFM with the metal wing or the all ceramic resin bonded bridges. These are some of my cases. There's the 2 unit, there's the 4 unit, and the 6 unit. 6 units, as far as I would go with resin bonded bridges, are only in the anterior zone, nothing posterior. I wouldn't even do a 6 unit conventional bridge on the posterior alone, RBB lah. So the design, you can have a cantilever design, which is the preferred design with higher success rate, which is proven true and true in the literature, or you can have the 2 retainer design, which is fixed. Depending on the circumstances, I will use one of 2 designs. Like this one is a cantilever design. If I were to replace 2 teeth, I usually use a fixed design, and then same for this one. So the advantages are multifold. So it's minimally invasive, you lose nothing practically. The disadvantages is sometimes it debonds. So if it happens, you can have it rebonded one more time. If not, you can just literally go for another option without causing much harm to your abutment teeth. So because the teeth is hardly prepared for anything, so you can start over with a new option, say a conventional bridge or an implant option. So it's much cheaper. There's lab cost involved, much cheaper, the appointment shorter, literally 1 appointment for minimal prep or no prep and impression, and the next one you issue. And then there you go, just two short appointments. It's a very versatile option. With implant, you have to be mindful about the angulation of adjacent teeth, say like the root angulation of your adjacent teeth. So you don't want to encroach into the root, if anything. If there was space lesser than 6 or 7 millimeter, an implant would be contraindicated. Whereas for this one, it does not take into account 3D space. It can be molded in any way you want. It can be a narrow tooth. It does not rely on root convergence or the adjacent tooth, so you can use it in any circumstances, to be honest. It also has very high success and survival rate. It's almost comparable to that of single implant restoration, according to the literature. However, not to say however. It's comparable. It has comparable long-term success rate to implant restoration, yet have less biological complication compared to implant restoration. Because implant restoration, as we will come to later on, has many biological complication and technical complication. However, if you have less enamel at a potential abutment teeth, is not suited because it relies on enamel bonding largely. So the complication is debonding, which is not a bad complication. It's easily managed. You can either rebonding or go for another option. Sometimes with ceramic RBB, it's more prone to framework fracture because ceramics are brittle in general. I've actually seen a couple of fracture of the connector of the zirconia RBB. Those cases I treated with metal ceramic RBB with metal wing because they're more robust. Ceramics are good, but however, there are still some pitfalls that you have to be mindful about. Like sometimes the old is gold, I would say, in some circumstances. So sometimes you can have the veneering piercing fracture. You can for that, you can actually have a composite repair, or you can redo the prosthesis altogether. So longevity RBB is very well documented in literature. So we have literature on metal ceramic or ceramic. Generally, systematic review use good short and long-term survival for resin bonded bridges, both metal ceramic or ceramic. It's a bit ironic to see that all ceramic has better success rate in excess of 90s to 100 even. We can even have long-term data of 10 years and more, up to 18 years in this case. So all the literature point towards the same thing: high success rate, high survival. So the most common complication being debonding. And then the fact that cantilever RBB has better survival and success rate compared to fixed RBB, and also zirconia RBB has lower chance, is strong, however, has a higher debond rate compared to glass ceramics, obviously, because it's harder to bond to zirconia than with glass ceramics, such as lithium disilicate EMAX. However, EMAX will have required a much thicker connector and a thicker retainer, so it's actually not very favorable in the anterior zone. Okay. So we have come a long way in terms of RBB. These are some of the cases I have replaced and restored in my department. So this case, upper case here, patient has an anterior open bite, wasn't wearing anything for a long time, not even dentures, because he had very severe gag reflex. So what we do, it was a perfect case, actually, anterior open bite, perfect case for resin border breach. In this case, I did a fix RBB. We just about managed to get a PVS impression with a sectional tray, very sectional. We don't even need the lower impression, for example, in this case. And then we just issued it straight away. No, not to say straight away. We just issued after 2 weeks. Patient was with the denture happy. At least she has teeth. She was a very attractive looking lady. However, due to gag reflex and whatnot, she went without teeth for years and years. So it was a simple solution, yet simple conservative solution. We only had to get an impression. That's the hardest bit actually. So another case, post-ortho, we had a zirconia RBV to replace the missing teeth. Obviously, we filled this fractured corner with composite and then take an impression. I think I did minimal prep and take an impression, sent to the lab comes back. We issued the retainer and then we make a new S6 retainer. All these cases are in combination with ortho. So ortho would have redistributed the space for the missing teeth, make sure it's symmetrical to the adjacent teeth, and then give the case to us at the end of debond. After they debond, they will send the patient to us. And then we replace the missing teeth and we make a new S6 retainer for them. Okay, another case, post-ortho, patient had financial constraints, so opted for a sort of a metal ceramic RBB as well. She was quite happy with it, even though it doesn't have the same aesthetic value as the zirconia RBB or ceramic RBB. However, patient was really happy because she had a dark space, missing space filled. Okay, some more cases of the lower missing incisors. And then this was done, it was a fixed RBB. I showed you this picture just now. So this was another case, unilateral case. We did with a metal ceramic RBB. And this was both upper and lower. This had a combined, we have missing upper laterals and lower centrals. So this case, we redistributed the space. It was quite big to begin with. It was almost larger than the central. So we had to do a bit of composite build-up in the upper to sort of improve the proportion of the central incisor related to the lateral incisor, and we did a fixed RBB, also acting as an orthodontic retention for the upper and the lower. And then we did new S6 retainer over it. And this is another case, also post-ortho. We did a fixed sort of retainer design. This will also act as orthodontic retainer, and obviously we're going to supplement with S6 retainer on top of it. I think last I reviewed him was at 2 years, 2 months. Everything was fine and dandy. To this point, probably 5 years on. So far, he hasn't come back. All right. So if you were to do a bigger span RBB, like such as this case, post-perio stabilization, you can actually do like you actually need a bit of small design because it involves like 4 teeth and then 2 retainers on either side. So we in order to sort of rehabilitate the patient's anterior zone, we need actually a bit of small design diagnostic wax out mock-up. So this is the wax out I came up with, and then it does seem a bit wide for the patient. Patient was a petite lady, was my patient. So when I did this wax up to fill up the space, actually the teeth looks very wide. So we went in again another wax up with a pink porcelain. I mean pink wax. Assuming this is a pink porcelain added to reduce the proportion of the teeth. So and then it looks better on the patient. Patient was really happy. The upper lower RBB, no preparation needed at all. And because it's upper against the lower, you can actually plan your occlusion guidance in such a way. You can take a Facebook record, multi-articulator. You can plan your guidance so that the pontics are not in guidance, and you only have canine guidance at most. So it's actually quite good in that sense. And this bridge I think, will stay on for a good amount of time because of this, because they are not in contact. And there's no potential of eruption of opposing teeth because they are both pontics, both upper lower pontics. Okay, so next I'm going to talk about fiber reinforced bridge. I know this is very popular nowadays. A lot of people, practitioners are doing it, and they are posting in social media, all sort of platforms. Some do it well, some do it not so well. I do not have a lot of experience with this. However, I am aware of this product. It's traditionally used to splint periodontically involved teeth or avulsed teeth, and now it's increasingly being used to replace missing teeth, both anterior and posterior. So the most popular product obviously is the GC Everstick. They actually have all the products for different indications. For example, GC Everstick Crown and Bridge. Then you have the Perio, GC Everstick Perio, GC Everstick Ortho. I think you even have the post nowadays that you can mold to the shape of your the shape of your post space. And then so you have the whole range of products for all sorts of indication. The advantage is that it's very versatile. It can be done in one single appointment, whereas the RBB will have taken 2 appointments because there's a lab stage and lab build involved. Very hardly any cutting of teeth. I think there is some preparation needed if your occlusion is sort of +1 or whatsoever. However, if there's open bar, you don't actually need to prepare the teeth at all. It's not to say cheap. The product itself is quite expensive. However, it's cheaper compared to the lab option, obviously, and it takes only a single visit. Patient can come in and go out with teeth literally on the same visit. And if the composite were to chip or whatsoever, it can be easily repaired, refurbished. It doesn't have to be you doing it. She can go to any dentist and anyone could have done it for them. So in that sense, it's actually quite good. However, the disadvantage is very technique sensitive. Obviously, best done with rubber dam, and not everybody have the training to use rubber dam. That's for one. And then not everyone have the training to do composite that well. Like I personally struggle doing composite in a lot of circumstances. I think there's a lot of very good clinicians out there. However, it's still something that I'm learning to do better myself in. The complication is actually manageable. You can have fracture of bridge, which can easily be repaired, and you can also have the lamination of veneering composite, which can also easily be done by anybody, because composites are something that we're very familiar in. Any GPs could have done it for the patient. Like there's some complication that occur with the FRC. So what does the literature show with FRC? So there have been to date 3 systematic review on FRC. The first one concluded that the use of FRC is still experimental. So it's something that hit and miss, something that's hit and miss. And the second one actually gives a reasonable survival of 70% at 4.5 years, which is not too bad. However, it's slightly lower compared to RBBs. The technical problem most commonly described a fracture of of the bridge and also the lamination of the veneering composite, again, easily repaired. And the final systematic review showed much more favorable outcome with FRC in that it's good. It's a very viable medium-term alternative for replacing single anterior posterior teeth in patients. So medium-term, long-term outcome, long-term performance still unclear. So we should just wait and see if there's any more favorable long-term results that come up to prove otherwise. All right. So the next one, I'm going to go to conventional bridge. Obviously, you know, conventional bridges are practically like crown, like multiple crowns, if it makes any sense. Like you have the supporting teeth crown to carry the pontic in the middle on the side or whatever design you fancy. With conventional bridge, it requires heavy preparation of abutment for full coverage retainer or crowns. It's easier to harmonize the appearance of the pontics and abutment because they will all be made at the same time. So if you have a very ugly looking teeth as abutment, you can actually improve it with the crown or the bridge abutment, so to speak. It's more retentive than RBB because it relies on conventional retention, so you can use any cement to cement it. Okay, there are different, again, 2 types, which is the metal ceramic and the old ceramic, much like the resin bonded bridge. So the advantage is that it can, like I say, harmonize or improve the appearance of abutments if they are not looking not that nice. Or if you're doing additive, like you want to increase you want to change the shape, size, angulation of the abutment teeth, you can actually easily done so with conventional bridges. It's more suited for heavily restored teeth, yes, then because you can improve the appearance at the same time. Also, however, it's not very conservative tooth structure because you practically prepping away all the enamel into dentine, so you lose a lot of tooth structure in the process. In fact, there's a study by Sorensen Edelhoff that showed, a lab study that showed that when you are preparing anterior teeth for either old ceramic or metal ceramic crowns, you actually lose about 63 to 72% by weight of coronal tooth structure. So that's how aggressive it is. Complication of conventional bridge, as I will come to later, are secondary caries, loss of vitality, porcine fracture, framework fracture, biological and technical complications. Yeah. And then conventional bridge, some of the cases, there's not a lot of literature on the use of conventional bridge in growing children and adolescents because obviously it's a very invasive treatment modality. So not many people do it at such a young age. So therefore, these are some of the cases I did. A patient is not so young, around, I think they're in the 30s. This is after peristabilization and around orthodontic treatment. Patient actually lost 4 centrals on the lower to periodontal disease. So she underwent obviously periodontal therapy and then orthodontic therapy to sort of have a more favorable occlusion to align all the rest of the teeth. And then I did a 6-unit conventional bridge prep 3-3 to 4-3, as conservative as I can, because I don't know how to do it otherwise. I don't know how to achieve this and orthodontic retention at the same time with fixed RBB. I feel like this is a better option. And bearing in mind, patient is already in her 30s. So that she's not that young anymore. And then next, this is an additive case. Patient, actually her requirement was she wanted a smile curve, like a smile design, like she wanted to have that smile arc when she smiled. So obviously this is not easily achievable with orthodontics, because her original teeth were quite small, quite small and quite short as well. So after around orthodontics, she was referred to me by an orthodontic colleague to sort of design the smile, sort of give her the smile art that she wanted. So because all the teeth, all the upper teeth are very heavily restored, we decided for crowns, additive crowns, and bridges. And also we did direct composite veneer on the 1-3 and 2-3. Because it's a more conservative, that we could have done ceramic, why not? Yeah, we did composites just to give her the small arch she wants. This is the final product. It was taken with a handphone because I don't have better pictures, unfortunately. And this is a small arch that she wanted. This was the provisional. I don't have a final photo actually, but ultimately she get what she wants. And it's additive in nature. So biological complication or conventional bridges are obviously secondary caries, loss of vitality, technical complication, porcine fracture, framework fracture, such as in the picture. In fact, if you see this OPG, you probably would have rather not do bridges for the rest of your life. There's failure in every single bridges that she has in the mouth. There's endo complication, there is secondary caries and endo complication, there is ill-fitting bridges and potential root fracture. As I will show you later on. So this is after I retracted the gingiva of the abutment teeth, and you can see there's gaps everywhere and secondary caries. This is what after the whole bridge was removed along with the screw poles, and then we extracted and transitioned her to denture. And the lower as well, she had a 6-unit EFM bridge done a couple of years ago by GDP. And then double abutted on the upper left side. Obviously developed endodontic complications. So we do an X-ray. Clinically, it doesn't look that fitted, like the bridge doesn't look that fitted. So the decision was made to dismantle the bridge instead of treating the tooth, one of the abutments, the 2-2 through the bridge. So we removed only to find that there was rampant caries on the 2-3 and also endodontic complication. And there also caries on the 1-3. So caries on the 1-3, endodontic complication on the 2-2, and then caries with endodontic complication on the 2-3. So like it's really quite destructive, I would say, if you were to do conventional bridges. And this is what we do. We do a RCT on the 2-2, 2-3, and then old-fashioned cast post and core, and then give the patient a 5-unit and a single crown on the canine. She was battling cancer at the time, so we kind of want to keep it as it is. We don't want to make too many changes. So as she has no other caries in the mouth, we reckon this will be the easier option than doing implants and whatnot, because she's after all a cancer patient. So biological complication, we often see secondary caries. Some are salvageable, some are not. Sometimes the bridges, we always see ill-fitting bridges as well. Some cause caries and demise of the abutment, yes. And some people are lucky enough not to have any decay. But when I dismantle the bridge, I can see that the gingiva on this side was really, really inflamed. And yeah. So some cases are not very salvageable. And then root fracture as well. If you use root-treated teeth abutment, there's a potential that will happen. Loss of vitality very commonly see as well. In this case, this was the case where I restored, I think I did a full mouth rehab on bridges in 3 segments, in 3 quadrants, increased OVD of the posterior segment with bridges. After 5.5 years, she developed an endodontic complication. There was a chronic abscess on the lower right 5, 6, 7, yeah, lower right 5. So we retreated that and then successfully healed the lesion. That was 6-month follow-up. And then the lower patient, however, was not very fortunate. She had a CAD-CAM bridge done by a GDP. She was sort of persuaded into it, do it on the spot. So she had a CAD-CAM bridge done. It was very aggressive prep. Right after the preparation, I think she developed pulpitis, which was unresolved for about 5 weeks because the GDP kept asking her to wait and see. So we did the root canal treatment ultimately through the bridge because she paid an arm and a leg for the bridge. We wouldn't want to sacrifice it by removing it and having single crowns instead. So we did a very conservative access cavity, and then this is what happens once we entered lah. Once we entered and flush, they will pass first, then bleeding later, and then and then shortly after, I think the 3-7 also developed palpitation. She knew it because it was the same symptom as she had on the 3-5, so she immediately seek treatment lah. She didn't wait until it festered into a full-blown periapical pathology. So this was after treatment. She was pain-free lah for now. Hopefully, fingers crossed, no other complication. So two similar clinical scenarios, 2 young ladies post-auto, development missing 1, 2, and 2, 2. Which one would you reckon? If it's yourself or your daughter or whatnot, which treatment option would you opt for? For me, I would probably go for the one on the right because I could preserve the whole abutment. Whereas this one, you literally had to prep the teeth for conventional retainer. However, this is a replacement bridge, so it has been done by somebody before. All we did was just refine the prep and then change it to a more aesthetic ceramic reconstruction. But however, the option is quite clear, like you definitely go for a more conservative option on the right. So what if you really have to like replace missing teeth with bridges? Like this case, I had no other options, post-auto, very young patient. I think she's 16 or 17. I had no other option. Patient was studying KL, only back for 2 weeks holiday. So we need to plan in such a way that we had the debond done by the orthodontist next door, and also replacement of missing teeth with fixed option at the same time together with retainer. So we had two weeks to do that. Plan it carefully, additive largely lah. If we really have to do like conventional bridges in young patients, we can always try to mitigate the risk by doing additive, like add to it lah. And then you use reduction guides to make sure you only cut what is necessary, just to accommodate the thickness of the material at hand. And then wherever that is not visible, you can always end up with metal margin. So you can do a very light chamfer all around, except for the buccal where you want to have porcine margin. And always follow up for long-term complications and intervene when necessary, yes. So I think finally we're going to come to implant supported prosthesis. So if possible, like I said, there's a risk of implant occlusion with young patients. So we always try to delay it for as long as possible, especially nowadays they say it's best to delay until late 30s lah. So prior to that, maybe you can always replace missing teeth with more like a resin bonded bridge or whatever to buy time until patient advance of age. Then you can change it to implant supported restorations. Okay, so these are some of my cases. You can have implant single crown, or you can have bridges, multiple units. These are, for example, this case was from this publication, and obviously 8 years after the procedure, patient had infra occlusion. So it was managed, but it was when patient actually went through a lot to get this and this to look the same. So this was obviously an implant, this was a tooth. So this is what happens if you do your implant too soon in your 20s. Okay. And then this is 2 cases that I came across during my training that I restored. The patient has oligodontia, which is hypodontia involving more than 60, multiple missing teeth in the mouth. So we went for the implant option, obviously to treat these. Very ambitious and very invasive indeed. So I'll just show you how we manage these cases with implants, and you can actually think later, would you have managed it this way, or is it the best way to manage it? Actually, it's probably not, looking back. So this is a case where we did full mouth rehab. So patient had, in collaboration with the MaxFX surgeon. So patient had about 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 implants placed under GA and extraction, immediate implants, bilateral sinus sleeve, and then 10 implants placed at the same time. Then we had to reorganize, obviously, because there was such a collapsed spine. We need to gain space, and then so we did a full mouth rehab on implants. Link everything, and then ultimately this is the outcome. This is the final prosthesis. And second case as well. However, this was done more conformatively, but with a resective approach, because like we mentioned just now, when the teeth doesn't develop, the bone doesn't develop as well. So where there's retained deciduous, there's very little bone in the sagittal section, and this is almost impossible to place an implant otherwise. So what he had done was a resective approach. The MaxFX surgeon actually reduced a segment of the bone to reach a wider base, and then did a ridge split, and you can see a green stick fracture on the side. And then we added bone graft and membrane on top of it. It was very, very invasive. Even on the upper, he had 1, 2, 3, 4, 5, 6, 7 implants placed at the same time. Even on the upper, there was deficient bone. He had to undergo GBR with membrane and bone chips. So very invasive surgery to have done one go. And you can see here that patient has lost a lot of soft tissue, hard tissue volume, and it has to be replaced with pink composite lah. So, and then this is the outcome. And this is another case that I came across. Patient had implants done a couple of years back, and now it's back for redo of restoration. You can see like the gray shine through of the implant fixture, if anything. So and then coupled with the case of infraocclusion, if you were, I mean, acid test, if this is the daughter, would you have planned for implant, or would you have gone the other way around? Yeah. Would you have gone for some more conservative option and buy time for implant until she advanced of age, until she's, I mean, much later on in life, or probably she don't have to have implants at all? Maybe a resin bonded solution would have been the final solution for her. So as I mentioned, implant complication is multifold. There are biological complications, technical complications. Peri-implantitis is actually a very big thing now. It's as high as 22% across all implants. And then mucositis is about 43%, almost half of all the implant patients mucositis. Can you imagine? So it's actually not a complication-free solution. Right. So what I would do nowadays, what I call combination therapy lah. It's a multidisciplinary approach involving usually my ortho colleague and myself. So usually, like in this case on the left, patient had multiple missing teeth, a lot of crowding. So we engage ortho to sort of align everything. She had actually missing 3 teeth on one side. We actually the orthodontist managed to reduce the missing missing space to two units, and replace the anterior with RVB, so she doesn't have to do bone graft. And also we replaced the upper right four with implants. Obviously, we built up the teeth with composite restoration because that's the most conservative solution at the time. And then, and also because if you do implant at the back in young patient, there's no risk of infraocclusion at the back. The most you do is you just change the restoration by additional porcelain. There's no aesthetic concern for the posterior region for having implants early on in life lah. So if you were to have an infraocclusion at the posterior, you can easily just change the restoration, making sure that it's a screw retain restoration, easy retrievable, easy repaired. Okay, this is another case where I combined with orthodontics. It was referred to me by other colleagues for replacement of missing 2 units, 1 and 2. She was originally missing 4 teeth, but however, our orthodontic colleague managed to reduce the quantity, redistribute the missing space to 2 units. It was still a little bit larger than 2 units. So what we do was we increase the width of the centrals on one side with fixed bridge, because it was a very heavily restored. She had a very heavily restored anterior segment. So, to improve the appearance of the 2-1 and 2-3, we decided to do a fixed bridge. Obviously, I put a fiber post in the 1-1, which was root treated prior to prevent cervical root fracture. And then this one, even though it's heavily restored, it's vital, it remained vital. So we did a composite build up to increase the proportion of the teeth in relation to the lateral. And then we did a resin bonded bridge, you can see here. So this is how she looked like. Luckily, she get away with murder because she had low smile line. And another case involving ortho and restore intervention. So patient hypodontia and microdontia, very sparse, tiny teeth, and then missing couple of teeth on the upper arch and the lower arch. So what we did was, we built the teeth mid-treatment. So orthodontic obviously tried to close out all the space after and before. And then there was one missing space, which is right here, that they couldn't close with the 4-5. So easily, because we had a root treatment done here, we got the orthodontist to keep the interocclusal space with a GIC block here. So I don't have to prep occlusally, if at all. So ultimately, the cantilever bridge for 4-6 replacing 4-5 was done entirely. We did enjoy normal prep because we had the occlusal space ready by the orthodontist help us to keep the interocclusal space for the 4-6, so we don't have to do any occlusal reduction. We just do a bit of circumferential reduction, and monolithic zirconia bridge, we managed to keep it as conservative as possible, keeping everything in enamel. Actually managed to bond this bridge with resin cement because all the preps were in enamel. So we gained quite good retention from the bonding as well. Okay, so how long will my restorations last? How long is a string? Every treatment for actually have a finite lifespan. You cannot you cannot do something expect to last forever, because we actually don't know what the patient is going through. At one point in life, the patient might be doing very well, but at another point he might be not doing so well in life, might be struggling socio-economically, might have personal problems, might have problem keeping the teeth clean as he had been in the past. So like sometimes they might fail in terms of oral hygiene and regimen and whatnot. So the best way forward is to try to provide them with options that are most conservative. Try not to remove too much hard tissue, soft tissue, easily maintainable, easily clean. So they don't have to do like, they don't have to do like the crossover super floss, what technique that they have to do on a daily basis if to maintain the prosthesis, for example. And then if the prosthesis is to fail, hopefully the complication is easily manageable. For example, like denture complications are quite easily manageable. Like if any caries, you can just do the filling. Anyone who have done it, you don't have to send it to a specialist. If a RBB debond, maybe you can still bond it back and have a second chance at it. If you were to fail in terms of root caries or whatever from a conventional bridge, or you have periimplantitis, it may not be as manageable. So try to delay that to later in life, like I mentioned here. Like I put it in the chart here. Yeah. So, and also if you can try to offer treatment that does not require multiple intervention throughout the lifetime of the patient. So obviously the best of all is no prosthesis, one being automatic space closure and the other one being autotransplantation. And it's more patient-centered to involve, like maybe you don't attempt the case on your own. If you see cases like that is quite complicated, maybe engage your restorative perio colleagues or a surgeon, try to offer them a alternative that is least invasive. Like if you cannot do the orthodontist, give it to somebody else to do. Like try to think of the patient instead of think of yourself. Try not to limit your treatment option to what you know best. Instead, let your colleagues help you out, so they can provide a very patient-centered treatment option that's best for the patient itself. And with that, I end my talk today. All right. Thank you.
Thank you very much, Dr. Khan, for the enlightening presentation. I hope our audience has benefited from your different case series. So we have now reached our question and answer session of the webinar. We have already received a few questions here. I just read out for you, Doctor.
Okay.
The first question goes like this. What are the main criteria where you would recommend a flexi denture, and how can we avoid the cons or negative aspects from flexible denture?
Right, I think the flexible denture only indicate very small span. Do not use it to restore like a big span like multiple teeth, because it goes against all the prosthetic principles. Like the support is not good because like basically it has no give. It has like it's bouncy, it's flexible. It doesn't like whatever occlusal force you apply for it will transmit to the underlying tissue, like underlying ridge and cause resorption. So it really is not meant for being long span. So if you were to choose it, if you were to really use it for patients who are actually allergic to PMMAs, for example, because obviously they couldn't have acrylic denture otherwise. And second, keep it to a small span. And thirdly, choose patient that is very conscientious, like they're very good at cleaning, patient who have low risk for caries or periodontal disease. And even that, additionally, you still have to check them from time to time to make sure there's no complication arising from the flexible denture, such as caries and whatnot. Yeah. Keep it to a very small span.
Okay, doctor, thank you so much. We have another question here. Are there any particular considerations for bridge fabrication in a growing patient?
Considering bridge fabrication, conventional bridge, is it?
RBB.
RBB. Can you repeat the question again?
Are there any particular considerations for RBB fabrication in a growing patient?
I think with RBB, you need to, the choice for RBB is obvious if you have like almost unrestored or minimally restored teeth with a lot of enamel. The choice is very obvious. Then the consideration is that obviously you want teeth that has a lot of enamel, like supporting teeth a lot of enamel, and then you kind of want to choose the teeth that has very robust root as well. So it can resist all the forces from on the two units. And then what more? like bigger surface area, for example, like say if you were to choose the abutment between 1-1 or 1-2, you obviously go for the 1-1 and or the 1-3 because it has larger surface area of enamel for bonding. Bonding is the key. So you want to maximize the bonding area, you want to maximize your retainer coverage, you want a abutment teeth that is very robust, that can receive forces, so to speak.
Okay, doctor, we have received just now another question. I just read out whatever the message they have sent. Hi, doctor. Thank you for your insightful sharing. I would like to ask for your input on the provision of any processes that crosses the midline. For instance, they had given one example. For instance, regarding a fixed RBB from 1-2 to 2-2 teeth, 1-2 to 2-2, will this have any impact on growth in the long term?
I think because it's limited to 1-2 to 2-2, all you do is spin 2 teeth, that's about it. I think the jaw growth will not be affected, unlike a denture where you spin everything up. So basically you just sort of prevent the 1-2 to 2-2 from moving, that's about it. It's pretty much like when you have orthodontics, you spin everything together. Just teeth, not the bone. I think there's not, because you're keeping your bridge to a small segment as opposed to the whole arch, so there shouldn't be any impediment to growth of your arch or development of your arch, so to speak.
Okay, doctor, that ends with our question and answer. I mean, and I can't see any more.
Doctor?
Yeah.
Sorry. Can I ask a question?
Yeah, go for it.
I'm Dr. Haziq from Hospital Banjaya. So on your lecture, thank you for your very enlightened lecture. So for now, I just have two questions. First is, you mentioned during your part on the osteotransplant, you mentioned that most of the cases was used to replace the lower mandibular anterior segment. Is it true, or is it
upper
just,
anterior, lower anterior can be as well? For premolars, most of the cases, both premolars being transplanted into anterior segment, yes.
Yeah, but the thing is, from my experience, if you want to replace the lower anterior, it's much more difficult due to alveolar ridge width. That's one thing. But it can be done. It's just that we have to do bone graft, we have to do horizontal augmentation. So usually for the lower anterior, we try to replace with other mean of prosthesis, not to transplant per se.
Yeah.
And then the second one, you explained just now that if you want to replace the upper anterior segment, 1-2 to 2-2, and then you mentioned that for RBB, there will no contraindication. But can I have your comment or your advice on because in growing patient we have this transverse growing pattern which is involve the mid-palatal suture. So if we breach at this region, the upper anterior region, it might somehow hinder the growth of the maxilla transversely. So what's your comment on that?
I think because you are spinning 2 teeth, what will most happen is the teeth will not move, however the jaw continues to go around it. I'm not very sure about the transverse suture whatnot, but generally because if you have resin bonded bridges, they can tend to be differential mobility. If there is movement of the teeth, it would have debonded. One would have debonded, it will be easily detected Yeah,
So
but however, if it's moving the same way, it's moving forward towards the front. If it's a similar mobility, differential mobility is towards the same direction, say 1-1, 2 and 2-2 would have been moving the same way, it would not have been affected. I mean, it wouldn't have debonded as a result. With the growth, it will still continue growing, but your teeth is moving the same direction. It's not moving one on side and one another direction, causing it to debond. Yeah.
Yes.
You can
Thank you so much for your comment.
You can also do a cantilever option. I have done it before, but it's just a bit harder because sometimes you can have spacing over time and whatnot. The teeth can move obviously as a result, individually as a result. Yeah.
Okay, thank you so much, Dr. Kong.
Yeah.
Okay, doctor, we don't have any more questions in our question box. So that brings us to our end of our webinar session. On behalf of MEPD, I would like to thank once again our speaker, Dr. Kong, for such an engaging and informative session. Doctor, I thank all of our attendees for your active participation. Once again, thank you all for joining us today.
Thank you. Thank you. you. Thank you, Vicky.